Hey guys, my name is Jenna Martin. I chose to do the case study 1.6 on coronary artery thrombosis and heart failure. It's personally interesting to me, but also I decided to do it because in my hospital, we do not really specialize or focus in cardiac. And I've noticed that some of our patients that come that do have cardiac issues while they're in the hospital don't have the best outcomes because of that. So it's something that I'm interested in learning a little more about so that I, as a RN on the floor, but also as a future practitioner, can recognize signs and symptoms and also look at the best possible treatments based on the research and evidence that's out there. So I'm going to review the actual case study itself and give a quick summary as far as the actual admission of this 65-year-old male and the leading complications throughout the weeks that ultimately led to his death in the hospital. So as you can see, this was a 65-year-old male who presented to the emergency department with severe chest pain, which was radiating down to his left arm. So just as we would have expected, we would have thought that he was having a possible MI or heart attack. So upon admission, they found that he had a complete left occlusion of the left anterior descending branch, about 2 centimeters from its origin, and they found this out by doing a coronary angio. So at this time, he received TPA and then was started on a daily regimen of 1 tablet of aspirin, which is like an 81 milligram basic standard dose of aspirin that we do with these patients. So being in the hospital about 1 week later, he started developing swelling in the bilateral lower extremities, so his feet and his legs, which was pitting edema, and then symptoms of an enlarged liver, and then swelling in his neck veins, which we know is JVD or jugular venous distension. From there, because of this, all the symptoms of fluid overload and heart failure that he was having, he was given diuretics and then put on a sodium restricted diet. Now, due to his fatigue and weakness, he was basically on bed rest while he was in the hospital. And several days later, he had pain in his lower right chest that increased with deep inspiration, and he had swelling in his left leg. So for us, anyone who works, I don't know, maybe ortho or anywhere in the hospital, really, this is a key thing where automatically we're thinking DVT, which is deep venous thrombosis. So at this point, and we're thinking that it possibly broke off and then traveled to the lungs and is now causing PE or pulmonary embolism. So at this point, intravenous heparin was started for this patient. But regardless, 2 days later, he developed severe shortness of breath and then died very suddenly. So we're going to look at some articles to kind of go into why things were done at this point and like why heparin was started, and then a little bit more of the patho of coronary artery disease and heart failure. So here we go. So just before we get into the articles and looking at a little bit of a different aspect of this case study, here are just some discussion questions that we're going to kind of work our way through to make sense of this case study a little bit more and just kind of break down what exactly is going on with this person in the hospital. So I think this case study is actually really interesting because it affords us the opportunity to see both arterial and venous thrombosis and kind of discuss some risk factors as well as the basis for these. So this question is kind of pertaining to the basis of thrombosis in the coronary artery, which we know comes from a lot of the risk factors that are present in this person before they ever get to the hospital with these acute symptoms. So we really don't know much about this person's past medical history or risk factors, but most likely he does have risk factors such as sedentary lifestyle. Maybe he's a smoker. He probably has a relatively unhealthy diet with high LDL cholesterol. He might have some arterial inflammation or systemic inflammation. So there's probably a lot of things going on here that have contributed to his coronary artery thrombosis and this clot that is in his coronary artery essentially that has probably stenosed and grown over time, but then maybe more acutely kind of I guess like the best word would be kind of like burst and then occluded the artery. However, we see later on with his leg swelling and stuff, this deep venous thrombosis as well, which is pretty interesting because the risk factors for this are more along the lines of sedentary, more like acute sedentary lifestyle, so more immobility, I guess you would say, not sedentary lifestyle, where we see he's on bed rest and not moving. And so this is causing a stasis of the actual blood, which is one of the three factors that for Chow proposed in his triad of causes for venous thrombosis, which is venous stasis, changes in the blood vessel wall, and changes in blood like coagulation itself. So this young man might, I guess he's 65-year-old man, might not just be because of his bed rest. He also could be predisposed to DVTs as well through some genetic factors, but that we really don't know. What we do know is he has some probably systemic inflammation at this point, as well as an enormous amount of stress on his body, and he's on bed rest, which has significantly contributed to his DVT risk. So at this point, we know that this man has an occlusion of his artery. So there's a couple of options that usually are available in the hospital. So oftentimes they go in and they do PCI, which is percutaneous coronary intervention, where they go in and they actually remove the clot or put a stent in the artery to open it up, or they use a balloon to open up the artery. At this point, this man was given TPA, which is a anticoagulant drug, which is really actually pretty fascinating. I'm more familiar with it from strokes, which is very similar to what's happening here, just happening in vessels in the brain instead. But anyways, TPA is tissue plasminogen activator, and essentially is given, it's considered a thrombolytic drug to dissolve blood clots, any type of blood clot really. This works by activating plasminogen, which basically ends up breaking down the cross-links between fibrin molecules. So it breaks down the structural integrity of the clot and essentially kind of dissolves it. TPA is more or less effective depending on the type of clot and the time that the clot has had to form. So usually we give TPA in strokes, we try to give it within like 2 hours. I think you can go up to 4 or even 6 now. The protocol has changed quite a bit. And so I think TPA was probably given in this case because his symptoms of cardiac pain were actually only for 4 hours, which I don't know if I discussed earlier in the case study, but it did specifically say that he had been feeling them for 4 hours. So due to that onset, is probably a huge part of the reason why they decided to use TPA rather than doing something a little more invasive. All right, so moving on to the third question regarding why aspirin was given in this case. So basically, any time someone comes with into the hospital with potential MI, myocardial infarction, or what we would call heart attack, it's standard protocol to give aspirin as a protective preventative measure. Now, unlike the TPA, aspirin is not going to break down a pre-existing clot, but what it does do is it inhibits the platelets from functioning properly and from sticking together, essentially, which will prevent further clotting, which is the hope. So basically what happens is we just give low doses of aspirin, like an 81 milligram dose, and it is very effective for preventing continued clotting or the growth of that clot, or even preventing other clots. So this patient actually developed edema twice in this case study, essentially, but 2 different types of edema. So the first time was about a week after he's been in the hospital. He started developing edema that was more generalized. So it was in his, as the case study explained, bilateral lower extremities in his feet and leg. He had pitting edema. Now I don't know how bad it was. It didn't say, it didn't give us a scale of the pitting, but what we do know based on this is that edema would have been caused by heart failure. So the stress that was placed on his heart due to the clot initially most likely caused some muscle damage and actual enlargement that then led to ineffective pumping of the heart and ineffective circulation, which leads to fluid overload and then congestion in the body. So that's the same reason why we also saw the jugular venous distension. So as that fluid kind of congests and backs up, you'll see it in edema in the extremities, in jugular venous distension, and then you'll also see it in liver enlargement. So those are all the key factors that made us go, whoa, this guy's having some complications with his heart. Now we need to offload this fluid. Which is why he was given diuretics and a salt-free diet. We didn't want him to be holding on to that fluid, because the more fluid is backing up, the harder the heart has to work, and it creates a cycle where eventually he'll go into acute heart failure and will not be able to maintain his body's circulation. So we have to do something to intervene there. Later on, so about 2 days after that point, he developed edema in one of his legs that was greater than the other leg. Now, this edema clinically would look a little different. It'd probably come with some redness, as well as like the swelling and warmth. So this edema was not necessarily due to the heart failure. This edema was different, and we know that it was due to a DVT in his leg that was likely due to the bed rest, which we'll talk about in the next question. So that's just an important differentiation. And honestly, if someone has enough edema in their bilateral lower extremities from heart failure that is not responding well to diuretics, potentially, it could be hard to actually identify a potential DVT, I would think. Except that oftentimes with DVT patients, not all the times, but oftentimes they do complain of pain in the lower extremity as well that is affected. So it's important to listen to the patient and really do full assessments on our patients and look and compare bilateral extremities always, whether it's pulses or edema. It's important to look and see that we have symmetry, I guess, where we would expect it. So any patient in the hospital is going to be at a higher risk for venous thrombosis of leg veins, particularly because most patients, even though we're, some of them are getting up with PT and stuff, most patients are experiencing prolonged immobilization at this point, or they're on bed rest. So this is very important to look for in specific types of patients that are on bed rest, cardiac patients, patients who, for whatever reason, can't be anticoagulated or can't take certain medications such as heparin subcutaneously to prevent it because of risks of bleeding or whatever the case is. DVTs are often caused common in ortho patients, spinal patients with injuries who are completely immobilized. So very, very important to be keeping an eye out on how much is our patient moving, how much are they able to move, are there any secondary things that might contribute to their immobility or risk for DVT. DVTs are very, very serious because the most feared consequence of a DVT is that that thrombus will break off and become a embolism, which will lead to pulmonary embolism. So that happens when, and it happened in this case study as well, we saw when the x-ray came back, we could see some shadowing in the base of the right lung, which and he was having extreme shortness of breath, which was likely due to a pulmonary embolism from his DVT. This could be very, very deadly, as it can cause massive pulmonary congestion, and essentially it's, in a lot of ways very similar to what happens in a heart attack in your lung. So very dangerous, can quickly lead to death if it's not treated well. And unfortunately for this man, he was treated. They initiated heparin, which is really another naturally occurring anticoagulant, sort of like TPA, but a little different. But yeah, so they started him on IV heparin, most likely a heparin drip, and we don't really know what happened from there, but we do know that 2 days later he died. So unfortunately, it is true that the risk of death from PE is still relatively high, even with treatment. So, best course of action as healthcare providers is to prevent it, do what we can to prevent DVTs in the first place, and um, secondarily prevent PEs as well, and be advocating for our patients in that way. So this first article is concerning tissue factor in coronary artery disease, and it's actually a very fascinating article. If you want, you should actually give it a read. Um, Really, tissue factor is a cell surface protein that is expressed in monocytes, macrophages, and fibroblasts. It's very active in the clotting cascade and in thrombosis in general. So basically what it does is it forms a complex with factor 7 and 7A, which we're familiar with from the clotting cascade, which then converts factors 9 and 10 into their active forms. So tissue factor is something that it's like it's a protein that is um, seen in healthy patients in small amounts in the blood and in the regular circulation. However, in unhealthy individuals, and interestingly enough, this does have a little bit to do with epigenetics as well, which I'll get into in a minute. I'll kind of discuss that. In unhealthy individuals, it is seen in elevated amounts, extremely high amounts, and even in the clotting area of plaque itself, you see tissue factor in higher elevated amounts. So it kind of becomes a cycle where um, it's in the it's already elevated, and then predisposing a person to thrombosis, and then that area of thrombosis also has an elevated um, tissue factor, which will um, create even more thrombosis in that area as it um, creates an ideal space for the macrophages to come to um, or stick to. So it kind of is like a clot begets more clotting kind of issue here, but very interesting. Um, the article also discusses treatment of this, talks about heparin, which I'll also talk about in another article, and a little bit more about some of like the risk factors. So in regards to kind of epigenetics, which I was mentioning, we do see that this tissue factor is involved with systemic inflammatory disorders, coagulopathies, atherosclerotic disease, and then some other diseases as well that are kind of getting away from what we're talking about, but tumor angiogenesis and even metastasis, which is um, just fascinating how involved this surface protein is. However, there is a positive correlation the article discusses between um, some what would be considered somewhat modifiable risk factors and some that are definitely modifiable risk factors. So elevated tissue factor goes hand in hand with glycemia, LDL cholesterol, and interestingly, number of cigarettes smoked. So here's an example of where our actions, whether positive or negative, can affect cell surface proteins, which will then affect um, risk factors and coronary artery disease. So we can positively impact that by changing our lifestyle as well. So this article does discuss a diagnostic test for plasma tissue factor, which is the tissue factor ELISA kit. However, it's not extremely specified, and the article does go on to say that this would be a great area of research to have higher sensitivity in tissue factor detection in order to um, basically just in order to be able to help create better outcomes for patients with cardiovascular diseases who are um, at greater risk due to elevated levels, and even to potentially be able to have high enough sensitivity to look at the effectiveness of particular interventions on this. So the second article discusses heparin specifically in the use of PCI percutaneous coronary intervention, which in this case study was not used because they used TPA instead, as I discussed earlier. But I do find this article interesting just in gaining a better understanding of heparin, the mechanisms of action, and understanding why we use this medication, and found it useful because this case study does discuss heparin, not necessarily in use of PCI, but this patient was put on an IV heparin drip for his DVT and PE. So the first thing I want to talk about that is important in this article and is important even to this case study is understanding the difference between heparin and TPA. So both are naturally occurring anticoagulants, but work a little differently. So TPA will break down a preformed clot, whereas heparin will not necessarily break down a preformed clot, but instead potentiates the body's naturally occurring lysis of that clot. So that's how heparin will break down clots, as opposed to TPA, which is why TPA was given immediately to break down the arterial thrombosis, and then heparin was later given to try to resolve the PE in our patient. As far as the pharmacology of heparin, it is important to know that heparin is extremely negative in charge and size, and for this reason tends to bind to surfaces such as platelet proteins, plasma proteins, and endothelial cells. But due to this binding, heparin can have pretty variable responses and can even have heparin resistance in patients. So we have to keep that in mind in watching the effectiveness of heparin, particularly IV heparins. So clinically, when we see heparin administered, we will see it administered most commonly in the hospital subcutaneously. And then in the case where we need higher doses of heparin and more continuous doses of heparin, we'll see it administered IV, like in the case of our man in the case study who had a PE. He wasn't getting heparin prophylactically, he was getting it as a treatment. However, subcutaneously, when we see heparin administered, in units, which we probably give to almost every single patient on our units, we do that for the main reason of preventing VTEs or DVTs, and trying to prevent PEs before they happen. You will not see heparin administered IM, or you shouldn't see it administered IM because of the risk of hematomas, and we don't give it PO because of the size of the negatively charged heparin is not well absorbed. Heparin also has an extremely short half-life, which is interesting in finding a balance of a therapeutic dose when we're titrating it IV drip. And then also important to understand and know, and just keep in the back of your mind in case you do give too much heparin, the antidote is protamine sulfate. So something that I did find interesting in the actual case study was that though it mentioned that the patient was started on a daily aspirin regimen, it did not mention that the patient was started on any type of subcutaneous heparin. And though they would have definitely waited until the TPA was out of the patient's system because of bleeding risk, that would have been long gone by the time a week had passed, or I guess a week and like 2 days, which is when the patient actually started developing the DVT and PE. So that would be something that I would question, is why was the patient not started on sub-Q heparin to hopefully prevent that DVT? And I don't know, maybe he was. We don't really know that information, but it was just a thought that I was thinking about as I was reading the case study. So this third article discusses oxidative stress-mediated atherosclerosis. It does discuss quite a few mechanisms of atherogenesis, including endothelial dysfunction, neovascularization, vascular proliferation, apoptosis, matrix degeneration, inflammation, and thrombosis. So it discusses quite a lot in this article. It's pretty packed full of information, but we are going to focus on a portion of the article that discusses epigenetics, just for the purpose of this case study and kind of looking at possible future applications of this study on healthcare as nurse practitioners. So just real quick, oxidative stress is basically an imbalance that exists when the capability of antioxidants in your body and then the activity of reactive oxygen, nitrogen, and halogen species, whether they're free radicals or non-radicals, become imbalanced. So this imbalance, which we know as oxidative stress, can cause injury to cells, mainly their proteins, lipids, and DNA, and can essentially signal pathways that will accelerate and cause atherosclerotic plaque formation. So the portion of this article that talks about epigenetics actually looks at it from a stance of how DNA methylation and histone modification can induce oxidative stress in atherosclerosis. So this is actually a little bit of a different kind of take on epigenetics. I think there's also an argument for how externally we can affect epigenetics to positively impact this as well, but this is talking strictly from a sense of how lower levels of DNA methylation and lower levels of histone modification appear to have a less of a role in atherosclerosis. So it's very interesting. We also, though, the article discusses the therapeutic effects of antioxidants on atherosclerosis and looking at how we can prevent cellular damage by increasing antioxidant intake to try to kind of restore this balance and in that way prevent atherosclerosis and use it as an actual treatment. So there's actually a lot of clinical trials going on with antioxidant therapy, and I think one of the limitations of this study that is very obvious is that some of these trials have been very unsuccessful, but there's still research being done, and they're looking at many different ways that antioxidants can impact atherosclerosis and cardiac disease, which will be interesting in future years to see exactly what this looks like. They look at vitamins and then other medications even that can suppress this oxidase activity, such as statins and other drugs that are able to mitigate oxidative stress. So this is definitely a direction that that science is moving in and looking at in regards to atherosclerosis, and it's going to be fascinating as we discover even more about this.